Hello everyone, how are you doing? This is Mikva Clinic by Dr. K. Today we are going to revise pneumonia in pediatrics. I have prepared this video based on the following references. The first one is Nelson Pediatrics 21st edition. The second one is WHO Pocket Book of Hospital Care for Children, 2nd edition. Pediatrics Hospital Care of Ethiopia, 2nd edition. MedStar Pediatrics 2nd edition, Farmos Pediatrics 1st edition, Dream Pediatrics 1st edition, Pediatrics and Child Health for Health Science Students, Lecture Note 1st edition. So we will summarize all the information about pneumonia in pediatrics age group, which means the definition, etiology, epidemiology, clinical manifestation, investigation, management, complication, and prognosis from all these books. So you are not obliged to read all these books. By simply watching this video, you can get adequate information about pneumonia in pediatrics age group.
Now let's come to the management of pneumonia. How do we manage pneumonia? It's easy. The management principle involves one is using antibiotics for treatment of bacterial pneumonia. The second one is treating the fever. The third one is giving adequate fluid, which is in the form of breastfeeding, and it might be giving IV fluids. The fourth one is feeding, and finally we have to arrange a follow-up for the child till he completely recovers from the pneumonia. So the principles of antibiotics, before we start our management or before choosing specific antibiotics, we have to know the severity of the pneumonia. How do we assess the severity of pneumonia? There is WHO criteria to assess severity of pneumonia. Pneumonia is classified as simply pneumonia or severe pneumonia. Why do we need to classify them? Whenever a child comes to OPD and we diagnose pneumonia, if it is simply pneumonia, we will manage that child as an outpatient. If it is severe pneumonia, we have to admit the child to the hospital. So, in order to admit the child to the hospital, we should know those severity features. What are the severity features of pneumonia? One is the finding that you get from your pulse oximetry, saturation. If the saturation is less than 90%, admit the child and immediately put him on oxygen. The other thing is the presence of respiratory distress features. What are those features? Nasal flaring, grunting, subcostal, intercostal retraction, and the like. Head nodding and the like. So these are the danger, which are the respiratory distress features are one of the severity features. The other thing is the presence of the danger signs, like if the child is unable to feed, and if the child develop loss of consciousness, convulsion, cyanosis, the presence of any of these danger signs, they are severity features. So immediately we have to admit the child to the hospital. And the absence of all these severity features, then we will diagnose him as pneumonia, community-acquired pneumonia, and we can manage the child as an outpatient. How do we manage a child with severe pneumonia? Immediately we have to admit to the hospital, give him bed. We should put him on oxygen. The preferred one is intranasal oxygen using nasal catheter. Nasal prong. So we have to put him on oxygen. The preferred one is using nasal prong, but we may also use nasal catheter, and occasionally we may use face mask. So we have to put him on oxygen till he maintains the saturation, which means until the SpO2 is more than 90%, we have to increase the liters of the oxygen. And our source of oxygen can be either oxygen cylinder or concentrator. We can use the available one. So we have to put him on oxygen. After putting on oxygen, we have to start him with antibiotics. As I mentioned, in neonatal age group, what are the common etiology agents? GBS and E. coli. So in order to cover these etiologic agents, we should start ampicillin and gentamicin, considering it as a sepsis. It's a separate discussion. We will discuss it in the future. And for a child beyond neonatal age, we have to start the child with crystalline penicillin. crystalline penicillin, 50,000 unit per kg, either IV or IM in QID base for at least 3 to 5 days. And if the child improves, then we can send him to home by changing it to amoxicillin. So this is the first line antibiotics given as an inpatient in management of severe pneumonia. But if the child doesn't respond to this treatment, we can go to second line antibiotics, which is ceftriaxone. Ceftriaxone 80 mg per kg daily dose is started. So these are the second, as I have mentioned, severe. We have diagnosed with severe pneumonia. We have already admitted the child, put him on oxygen, starting with antibiotics. Then we have to manage the fever, because the fever by itself causes distress. So we can manage the fever using PCM. It's better to use the PCM suppository, because the child is unable to swallow, or there is also a risk of aspiration due to respiratory distress. So suppository is advised. So this is the way how we manage fever, especially if the fever is above 39 degrees Celsius, we have to manage it. If he is unable to feed, we have to start NG tube feeding, because don't forget that there is a risk of aspiration in the child with respiratory distress. If there is severe wheezing associated with pneumonia, bronchodilators can be used. And finally, don't forget to start with zinc. Zinc is good. Usually, zinc is used to manage a child presented with AGE, acute gastrointestinal infections. But it's also suggested, or it's also beneficial, it is also advised to be given for a child presented with pneumonia, because zinc is important for the recovery of the epitheliums in general. So the child will have this healthy respiratory epithelium, so he will be able to protect himself. Don't forget to give zinc supplement. Zinc supplement is given with a dose of 20 mg per kg, 20 mg daily for a child above 1 year, and for a child less than 1 year, 10 mg per day for a total of 7 days advised. So this is how we manage a child presented with severe pneumonia. When do we discharge this child? When there is no the danger signs, which means the cyanosis, the respiratory distress, if the child is able to feed now, if the mentation is normal, the absence of all these danger signs, then it is one of the criteria. The other thing is, we have to advise the mother on danger sign, because a recurrence of pneumonia may occur. And during discharge, the zinc supplement should be continued, and we have to change the IV medication to pure. Commonly we use amoxicillin with a dose of 40 mg per kg per dose in the PID base for at least 5 days. Or in case of area resistant to these antibiotics, we may also use augmentin with the same dose and with the same dose and duration of treatment. So this is, and we have to arrange a follow-up to the child after 2 weeks. This is how we manage a child presented with severe pneumonia. But in general, treatments of pneumonia as an outpatient child, it's easy. Give him amoxicillin, 40 mg per kg per dose BID for 5 days. And if there is resistance, or if there is any previous treatment with these antibiotics, we may use augmentin with the same dose and with the same duration of treatment. And we have to appoint the child after 3 days, and we have to assess after 3 days. If there is improvement, that's good. Just send him home and tell them to finish the medication or the antibiotics. If there is no improvement, we have to admit and search for the cause or underlying cause, or the reason why he is not improving. If there is any severity feature, again you have to admit and manage as severe pneumonia. Additionally, we may use antibiotics azithromycin, especially for children above 5 years of age. Chlamydophila and mycoplasma pneumonia is expected etiologies for pneumonia, so we have to add azithromycin with a dose of 10 mg per kg in day 1 and 5 mg per kg from day 2 up to 5. For older children, we may prescribe as 500 mg for day 1 and 250 mg from day 2 up to day 5. The reason behind this is in order to cover those atypical causes of pneumonia. Additionally, or as an option, if there is no azithromycin, clarithromycin can also be used. But clarithromycin by itself is not usually available, so azithromycin is more available, but clarithromycin can also be a possible option for covering this atypical cause of pneumonia with a dose of 50 mg per kg per day. So after providing with antibiotics, always we have to provide with zinc with the same dose as I have mentioned earlier. And we have to advise on danger sign, because the child may not have severity features during presentation, and later on after he go to his home he may develop those danger signs. So we have to advise the mother to follow the child for the presence of any of those danger signs. Then we have to advise on risk factors. The best way to prevent pneumonia is advising on the risk factors.